Thank you, Claudia. My name is Veld, and I'm working as an anesthesiologist in The Hague in the Netherlands. First of all, I'd like to apologize for my voice because I'm in the midst of a laryngitis, so if you can't hear me, it's not your problem, really. Our guideline is aimed to provide an overview of the present knowledge on the subject of with an assessment of the quality of the evidence, as Ian told you already. For today's presentation on the use of preoperative carbohydrates, we used 20 of the over 7,000 abstracts that were retrieved by the Cochrane group. I won't go into detail into the design criteria, as Claudia and Ian already did that. What will I discuss? In today's presentation, I'll briefly discuss some history, elaborate a little on the why the use of carbohydrates could be important. Subsequently, I'll briefly discuss the published outcome-related research with regard to the safety and the potential benefits. And then I will end with the two recommendations we decided upon related to the use of carbohydrates as part of the guidelines. As you all may know or may not know, it was around 1848 or 1847, depending on the country you listen to, that the first described anesthesia-related aspiration with fatal consequences occurred. It was a young woman who was put to sleep with chloroform. She did eat, of course. It was she subsequently aspirated and died. And ever since, over 140 years, it has been proposed that a prolonged period of fasting should precede anesthesia to allow for gastric emptying. And this routine was, and still is, as you just heard from Claudia, one of the most propagated medical routines worldwide. If not by the doctor, then by the patient. And in the late 1980s, however, it became clear that this routine was not safer than drinking clear fluids up to 2 hours before surgery, or before anesthesia, in fact. Guidelines were again subsequently gradually changed and adapted because patients felt better after drinking clear fluids than after drinking nothing. Well, this concept has recently been developed further. There's now evidence that undergoing surgery in a carbohydrate-fed state, it was a new term for me also, has important advantages over the classical preoperative fasting. Now, as I hope to show you, some of these advantages may be attributed to the reduced postoperative insulin resistance. To understand why insulin resistance is important in the postoperative phase, one has to understand what it is and when it occurs. So without going into detail too much, I'll give you a short refreshment. Most people, this audience not necessarily included, tend to sleep during the night as part of normal life. And once awake, most people have something to drink and to eat. And then when these nutrients are consumed, glucose levels rise and insulin is released, causing a series of rapid metabolic changes. Gluconeogenesis is shut down and glucose is released and is not released anymore from the liver. What also happens is that in the muscle, specific glucose transporters are activated to enhance uptake of the glucose. Cells change from fat metabolism to glucose metabolism. This insulin-dominated action, in fact, lasts for approximately 3 or 4 hours. And since people eat every few hours, this process, in fact, lasts during the day and fades away during the night as intake stops and insulin levels drop. This is, in fact, the transition to the fasted state, and later on, when it lasts, to starvation. During this fasted state, the interplay of glucagon, cortisol, IGF-1, and growth hormone contribute to a state of relative insulin insensitivity. This insulin insensitivity remains until again there has been a sufficient caloric intake, which is usually the next morning. For today's presentation, it's important to recognize that the fed and the fasted state represent two fundamentally different metabolic states with different metabolic processes. The end result is that a patient who is operated in the fasted state starts from a lower level of insulin sensitivity as compared to the one who's had breakfast, or in this case, carbohydrates. And furthermore, it's important to recognize that the current liberal guidelines on clear fluids do not convert patients to a fat stage, since most clear fluids do not contain energy, if no energy, or if mostly 1 or 2 moles of sugar. That's not enough energy to activate the metabolism. Well, this renewed acquaintance with the glucose metabolism is only relevant when there's a relation between the setting of the metabolic state and the body's reaction to stress or injury. The fact that a poor nutritional status and weight loss are correlated with outcome is already long known. Approximately 75 years ago, it was discovered that, for example, fracture metabolism was influenced by changes in metabolic state. And later studies showed that even a short period of food deprivation impacted on survival rate following, for example, hemorrhage in rats or cats. Later animal studies indicated there were clear advantages in being stressed in the fat state than in the fasted state. So a particular metabolic state at onset of injury was related to the outcome parameters. So yes, there is historical evidence of a relation between metabolic state and outcome in stress. So although teleologically insulin resistance is a natural response to starvation and injury, it is questionable whether this response is beneficial for the patient or even harmful for patients undergoing elective surgery. In order to answer that question, it's important to know to what extent this insulin resistance occurs in elective surgery, if it's in fact the metabolic event related to outcome, and if so, whether it can be overcome by preoperative interventions. Early studies showed that the degree of insulin resistance was determined by the magnitude of the insult. So the larger the surgery, the larger the higher the state of insulin resistance. Subsequent studies showed that in the early phase of the surgery, insulin resistance mainly occurred in the muscles and only a few days later in the liver. In the muscles, there was a reduction of the glucose transporter GLUT4, causing the patient not to adequately respond to glucose challenges. Therefore, glucose could not enter or cannot enter the muscle cells, and glycogen production is stopped. And it may last for over a month, so far after surgery. Recent evidence also indicates that because of surgery, there is an upregulation of pro-inflammatory genes. And this upregulation leads to the sustainment of the state of insulin resistance. And in addition, the release of cytokines, as a cause, also caused by surgery, also promote the state of insulin resistance.